Hi, most of you are familiar with the recent guidelines, the update of the European consensus guidelines on RDS management. As you are aware, the first version of this came up in 2007, and consequent to that, every 3 years they have been updating this. The same group of authors, and of course, we'll miss Professor Halliday. The important aspect here is that the guidelines are developed on consensus basis based on currently available evidence, and it has become a popular resource for neonatologists around the world. So one request for the authors, the group of authors who are involved in it, is to see if we can be independent of the financial input from CAISI, which is supporting this initiative from the beginning. Of course, if it is used in the right way, there is no impact on the decision making or the value of the guidelines, but it would be much better if we stay clear of market influence when we make such guidelines. That is just my personal comment. I'll be reviewing the recommendations part and then discuss a little bit about each aspect as applicable. And as has been the case from the beginning, they cover all aspects of newborn care which can impact on RDS management, which is very commendable, a good approach. And prenatal care, the recommendations are that the mothers at high risk of premature delivery, less than 28 to 30 weeks, should be delivered at perinatal centers with experience in management of RDS. So depending on where you work, the setup may vary, the government regulations may vary. For example, in the UAE, we have regulations as to the level of intensive care, what categories of babies can be delivered there, and obviously you need to recognize what you can do in your unit, and in utero transfer is much better than ex utero transfer after stabilizing. Even for stabilizing, a unit which deals with a few of these babies will not do as well as compared to a bigger unit who deals with this day in and day out. The second point is about women with singleton pregnancy and short cervix in mid-pregnancy. Vaginal progesterone treatment should be used to increase gestational age at delivery, as well as reduce the perinatal morbidity and mortality, which is in turn linked to the prolongation of gestational age. So most of this is based on the Optimum study and other studies before that, where they gave vaginal progesterone to the mother and also looked at the immediate outcome as well as neurodevelopmental. There is a potential for improving the gestational age at delivery where there is a risk of preterm birth. So this is widely used as well, and it's a safe treatment, so it should be encouraged. In women with symptoms of premature labor, cervical length and accurate biomarker measurement should be considered, mainly to prevent unnecessary use of tocolytic drugs and or the antenatal steroids. So this is a very important point when it comes to reuse of antenatal steroids, because if you use it the first time when it is not clearly indicated, you are more likely to need it again, and actually when the delivery is happening you may not be able to give it because you're already exhausted your two courses that you may be able to give. I would request you to go through my video on update on antenatal steroids to get more details about this, but it's very important to be clear about confirming the real risk of premature delivery, not have a low threshold just because it is multiple pregnancy or you're over-diagnosing the risk. And so do go through these cervical length and biomarkers like fetal fibronectin before you actually decide. This is an observation to feedback to your obstetric team. The clinician should offer a single course of prenatal corticosteroids to all women at high risk of preterm delivery from the time pregnancy is considered potentially viable. So this has come down to 22 weeks in many of the developed countries. So if there is a high risk of preterm delivery, even after 22 weeks up to 24 weeks, according to your center, you may consider giving it, because research has shown even at 22 weeks, antenatal steroids improve the survival. The gestation cutoff is 34 completed weeks. Of course, the ALP study came up with the recommendation to give steroid between 34 and 36 weeks, but there are subsequent studies where antenatal steroid exposure may result in long-term neurodevelopmental concerns. Most of this is related to studies on babies who received steroids antenatally but went on to deliver close to term. Remember that about 50% of the time when antenatal steroids are given, the premature delivery doesn't happen. That takes us back to the same point here, where you need to be sure of the risk of preterm delivery before you give steroids. And any setting like a maternal urinary infection or any other concerns which necessitate this dose of steroid at that time might itself compound the neurodevelopmental outcome of these babies. I have discussed this in relation to paracetamol use in pregnancy and long-term neurodevelopment, because paracetamol is used to treat fever, and if the mother has fever, we know that there is a cytokine response and this could impact the fetal neurodevelopment. So it's not that paracetamol is causing the neurodevelopmental problem in the baby, but it is more the association of paracetamol use. The same association may exist for this antenatal steroid use as well. So of course we shouldn't use steroids on a repeated basis during pregnancy, and that's why the consensus is to use a single repeat dose which may be given in threatened preterm labor before 32 weeks if the first course was administered at least 1 to 2 weeks earlier. So it's only one repeat that can be given. So if don't, the obstetrician should not have a low threshold to give the steroids, and they should delay as best as they can if they are not sure about whether it's a preterm labor or not. And then the repeat course can be considered 1 to 2 weeks after if the preterm delivery becomes imminent. So again, they have to be sure that it is really imminent, because they will only be able to use it once. Magnesium sulfate to reduce the risk of cerebral palsy is recommended below 32 weeks, and again the gestation cutoff at which you would start giving it is debatable, whether you would give it below 24 weeks or you would restrict it to 24 weeks and above. Some people are of the opinion that you can give it for 22 to 24 weeks, but I personally feel we can wait till 24 weeks for MagSelf, mainly because the risk of cerebral palsy is very high anyway before 24 weeks. The survival chances are lower, and these are the babies where magnesium sulfate related gut motility could affect feeding tolerance and other issues as well. The clinician should consider short-term use of tocolytic drugs in very preterm pregnancies to allow completion of a course of prenatal steroids, and also to consider in utero transfer to perinatal center. So the tocolytics should be used in settings where you gain from it. So you don't want to arrest preterm labor where there is a setting of infection, where there is corium neonitis, or where there is a risk to the maternal health. But if there is a possibility of prolonging the pregnancy, getting the steroid dose to the maximum benefit, or to allow you to transfer, then you use the tocolytics. So I request you to share this segment of it with your obstetric colleagues. The same applies to the delayed cord clamping, which will come in the labor room criteria next. In terms of the labor room care, the recommendations include obviously deferring the clamping the umbilical cord. So delayed umbilical cord clamping, we can also name it as late umbilical cord clamping, or the physiologic umbilical cord clamping. So the cord clamping should be delayed unless there is a real contraindication. So that is physiological. You can review my videos on delayed cord clamping for more detail, but it is physiologic. It is the blood that should be coming back to the baby, and in a premature baby where hemodynamic disturbances are much more likely, the lack of this 20 to 30% blood volume will impact the baby's outcome. And that's why if you miss out the 20-30 ml of milk, the blood that the baby is supposed to get back, these babies can have a higher risk of IVH. The risk of jaundice is very minimal. You don't need to be worried. And even though there is a mild polycythemia, because the blood volume increases at the same time, it's not going to affect the risk of hyperviscosity in these babies. So please reiterate that you should do delayed cord clamping. Again, teach your obstetric team that these babies, when they are premature, don't cry, they are not vigorous at delivery. Encourage them to feel the cord pulsation, and if the cord pulse rate is more than 100, they can safely wait 30 seconds to 1 minute. Again, the labor room temperature should be clearly adjusted to 24 to 25 degrees as recommended, and OT temperature as well. So you need to negotiate, educate your obstetric team the importance of this, and don't leave a choice. It's almost like what the baby should be getting. You shouldn't deprive the baby of this. Another important point is the stem cells that this fetal blood is rich in. All the immunoglobulin that was transferred to the mother, the dose that will come is like 20 to 30 ml per kilo more of the blood volume, which has this high, very rich in stem cells as well as immunoglobulin, which will play a big role in helping these babies cope with the stressful newborn period. So please don't miss out on delayed cord clamping. Cord milking can be considered in babies more than 28 weeks, but in the babies who are younger than that, there is a risk of possibly increased risk of IVH, as shown by Anup Kataria and his team. So we have to be cautious about cord milking in the smallest babies. For the resuscitation part, T-piece device should be preferred rather than bag and mask. So obviously the benefits are clear that you adjust the pressure better, you can deliver PEEP better, the inflation time is regulated better. There is no role for prolonged inflation at delivery. Sustained inflation is not recommended. Spontaneously breathing babies should be stabilized using CPAP, so don't immediately intubate the baby. If they are apneic or bradycardic, start giving ventilation breaths. And the expert consensus is to start with CPAP pressure of 6 centimeter water with a PIP of 20 to 25 centimeter. So obviously if the baby continues to need IPPV, then you intubate these babies. Oxygen for resuscitation should be controlled using a blender. So this is not an option anymore. Any unit taking care of newborns should have blenders in the labor room and in the NICU as well. We should use an initial FiO2 of 0.3 for babies less than 28 weeks gestation and 0.21 to 0.3 for those 28 to 31 weeks. So room air is adequate for more than 32 weeks. So it's important that we start with some oxygen for the smaller premature babies, and there are still studies on Torpedo 2 and so on, which are looking at ranges in between. So the Torpedo 1 had looked at 100% versus room air, versus the Torpedo 2 is giving different cutoffs. So we can go 30 to 60% maybe to start with. And because the oxygen is important to maintain the airway open as well in the small babies, and it has been shown that a saturation of 80% or more to be achieved within 5 minutes is important for a better prognosis. We can consider titrating, starting with 30 to 40% and titrate down. So the smaller the baby, the higher the need for this slightly increased FiO2 at delivery. We should hopefully get more clear information on this soon. Intubation should be reserved for babies not responding to PPV via face mask or nasal prongs. There are some resources looking at laryngeal mask airway for the initial inflation. Again, for the bigger babies, most people are suggesting we can use LMA above 1.5 kilos, and experience is increasing. Once we get the 0 size, probably this will increase as well. So the seal efficacy is much better. If you are using a face mask, remember that the trigeminofacial reflex can cause reflex bradycardia. So be careful about how you hold the mask, not to press too hard, and to relax and make the seal effective in an appropriate way. And there are also studies which are looking at use of high flow at the time of delivery. That's not established practice, that can be considered in your unit if you are able to set it up. 2 people doing the IPPV is also beneficial. 1 person stabilizing and holding the mask with a good seal, and the other one doing the bag. If you have facility, go for these options. And plastic bag or occlusive wrapping under the radiant warmer, and the humidified gas should be used during stabilization of babies less than 32 weeks gestation to reduce the risk of hypothermia. Hyperthermia should be avoided as well. So some people have looked at servo control temperature regulation. It doesn't change the outcome, but anything that improves the awareness, the focus on the labor room temperature, the focus on using the warmer properly, using the plastic bag. Sometimes when we use a thermal mattress, babies have been shown to become hyperthermic, so that should be avoided. So we have to be watching for both hypo and hyperthermia prevention. The next important aspect is surfactant therapy. So you can review the video I posted recently on the pragmatic approach to RDS management, and that covers most of these parts. I mean, even though it was before the guideline came up, most of it would agree with what is mentioned in the guideline. If a premature baby less than 30 weeks gestation requires intubation for stabilization, they should be given surfactant. So that is well agreed. These babies have already been intubated and very high risk of RDS. So the earlier you give surfactant, the better. So you can give surfactant to these babies. And babies with RDS needing treatment should be given animal-derived surfactant preparation. At the moment, we don't have a synthetic surfactant which is marketed with appropriate evidence, even though we are likely to get something in the pipeline soon. Leucinactant has been withdrawn from the market, so we have to wait for the next product. LISA is the preferred method of surfactant administration. So this is based on recent evidence. Again, I have just published another video looking at the non-invasive ways of surfactant administration, and either LISA or INSURE can be used according to what your unit practices. The guideline is suggesting LISA as a preferred method. Laryngeal mass surfactant may be used for more mature infants more than 1 kilo. So again, I've discussed that in the other video. I'll refer you to that. So don't be fixated on which non-invasive way. The main aspect which is going to damage the lung for risk of BPD is prolonged ventilation. So as long as you're not intubating and keeping the baby intubated for a long time, you can use whatever suits you best. I have used INSURE mainly in our unit and it works quite well. In practice, the BPD rates are lower than what is reported elsewhere. For Poractant alpha, we all use a 200 milligram per kilo higher dose, initial dose, because it has shown a reduced need for further surfactant as well as improved survival. For Biractant, you use 100 milligram per kilogram. If you are using a second dose, you go to 100 per kilo for Poractant as well. The rescue surfactant should be given early in the course of the disease. So some of you had discussed the need for IPPV, NIPPV versus CPAP in the initial stage. So we restrict to CPAP of pressure 6 to 8 centimeter of water or FiO2 up to 30. And if the baby doesn't cope with it, it's better to give surfactant to these babies as it's likely RDS. And you don't want to use a high pressure on a lung which has significant RDS. A higher risk of air leak will ensure, and the higher pressure used may not be good for the baby's tummy. A higher risk of SIP possibly is there. So if the lung ultrasound suggests, you can decide on the surfactant. And please, as I've discussed in the video on the pragmatic approach, remember that all of these, the FiO2, RDS risk, and the findings on X-ray are variable. It's an evolving disease, so you need to be careful about it. A second and occasional third dose of surfactant should be given if there is ongoing evidence of RDS, like persistent high oxygen requirement, after other problems have been excluded. So most of the time we don't need more than 2 doses. I have not needed a third dose recently. And even the second dose is very infrequently needed these days. If you have used less invasive surfactant for the first dose, you can use it for the second dose if the baby is coping otherwise. There are some indications where you want to keep the baby intubated if the CO2 is very high, if the baby's work of breathing is very significantly abnormal, or there is a risk of PPHN or infection. You can have a lower threshold to keep the tube in for a few hours to decide on the subsequent course to avoid repeated intubation efforts. So this is a summary of what we have for surfactant therapy. In terms of oxygen supplementation after the stabilization, in the premature babies who receive oxygen, the saturation target should be between 90 and 94%. This is the evidence based on the support and the boost 2 studies, and it is well established now. The alarm limits, of course, you may decide individualize it on the baby, but the recommendation is 89 to 95%. This is always a debate as to what your upper limit setting should be to avoid over intervention, and obviously the nursing time, the effort is considered as well. So you can go up to 96 or even 97% in the babies who are very sensitive to slight adjustments in FiO2. For example, you have less than 25% oxygen, and if you keep 24%, the baby desaturates, and if you keep 25, baby goes to 97. It's finely tuned, so in these cases you can individualize and keep the setting about 96 to 97% as upper limit. The same applies to the lower limit for a baby who is labile and keeps dropping. You can consider 87 or 88 for a brief time. So these are individualized decisions, and you should document it in your plan. And if you educate your nursing team, they themselves will become aware of what settings they need to do this. But definitely increasing the FiO2 delivery will affect ROP risk, and so we have to be very cautious, especially in the extreme small babies who are at the highest risk of ROP. And protocols for screening and treating premature babies for ROP should be in place as well. So this is very important, and all of you may be familiar with the ROP guidelines in the developing countries having a little aggressive approach compared to the ROP guidelines in the developed world. That is because of the aggressive posterior ROP development in some of these IUGR or nutritional deprived babies. Again, it's very important to discuss the role of closed loop oxygen monitoring. There are studies coming out that these are beneficial, but we need the exact ideal algorithm which avoids the oxygen requirement going too high. And again, one of the disadvantages possibly is that you may delay picking up a baby who is deteriorating because otherwise the nurses might have alerted the team earlier. So We have to see the range which is acceptable, and the algorithms have to be fine-tuned to that. In terms of non-invasive ventilation, we have CPAP or NIPPV started at birth in all babies at risk of RDS. So here I would slightly differ that NIPPV at birth we can delay till you make the decision on surfactant use. So as I mentioned in the other video on pragmatic approach, I'll link it with this video as well. So if you start NIPPV, you may start giving higher pressures in a baby with RDS without the surfactant from which they would benefit. Of course, if you are in a resource limited setting and you are monitoring closely, you can use NIPPV, but if you are in a developed country and you are not limited by resource limitation, better to start with CPAP of 6 to 7, and if oxygen requirement is rising or if the work of breathing is increasing and you think baby needs an NIPPV, better to give surfactant by LISA or INSURE before you go to NIPPV. So babies less than 30 weeks gestation who do not need intubation for stabilization, you start with this. Non-invasive ventilation with early surfactant by LISA is considered optimal management. So this is a big shift over the past 10 years or so. There is no role for prophylactic surfactant, but early rescue by LISA is suggested. The system delivering CPAP is of little importance. So bubble CPAP, infant flow driver, ventilator CPAP, they all work similar. Slight differences will be there. You have to use what works best for your setup. The interface should ideally be a short binasal prong or mask with a starting pressure of 6 to 8 centimeter of water. Ability to escalate NIPPV will reduce the need for invasive mechanical ventilation in some infants. So obviously they're acknowledging that NIPPV is better than CPAP alone, and that's the experience most of us feel. There are discussions about the interface for NIPPV, whether RAM cannula can be used. We have used RAM cannula, but you do need to increase the pressures to offset the resistance that the circuit provides. And usually we see that RAM cannula NIPPV is a little less effective compared to NIPPV with the ventilator provided interface, but it is still better than CPAP. So you have to titrate and use according to what is available to you. BiPAP devices confer no advantage over CPAP alone. So this is again biphasic CPAP using the VIAS device. The infant flow driver works a little better. You can recruit more, but the effectiveness is not going to change much. Synchronized NIPPV, if delivered through ventilator, can reduce the need for ventilation or need for reventilation following extubation, and it may also reduce BPD. We also acknowledge the role of high flow nasal cannula as an alternative to CPAP. In the text, the authors say if the unit has enough expertise, you may be avoiding the use of CPAP or NIPPV, but again, it does appear clinically a little inferior to NIPPV or a higher level of CPAP. So if the baby is in the evolving phase of RDS, it's better to go for CPAP or NIPPV and then step down to high flow once we know they're stable. High flow works on babies who are stable on 5 centimeter CPAP or below. It's based on what we have experienced. Again, the point about how long to keep the high flow, don't be in a rush to wean the smallest babies off the high flow or CPAP. When they are evolving with the feed progress, the reflux and the intermittent hypoxemic episodes will be reduced if you have an option to recruit the lung volume or support the babies from de-recruiting quickly. So keep a pressure of 3 to 4 centimeter 3 to 4 liters flow with high flow or 4 centimeter CPAP. For babies under 32 weeks or under 1.25 kilos, till they cross this threshold. When they're free of intermittent hypoxemic episodes, then you take them off, then you are likely to stabilize them better. In terms of mechanical ventilation, so mechanical ventilation is limited to babies with RDS where other measures have failed, and duration should be minimized, so you try to extubate at the earliest. There is no doubt that lung protective strategies like volume targeted ventilation, volume guarantee, or high frequency should be the first choice. I'm not sure why they put high frequency as the first option when majority of the units don't use high frequency as the first option. Most of us keep high frequency as a rescue, but with more advancements in high frequency, the ability to use at higher frequencies like 12 to 15 hertz and volume targeted high frequency, if you have these facilities, you might start using that as a preferred mode. One of the issues with high frequency is obviously the need for sedation, which it doesn't look right not to sedate these babies, while in conventional ventilation and volume targeted modes we get away without any sedation. So we still would vote for volume targeted rather than high frequency. But if the baby has worsening, you can have a low threshold to switch to the newer high frequency modalities, especially with volume guarantee. When you're weaning from mechanical ventilation, it's reasonable to tolerate a modest hypercarbia. The threshold to which you accept permissive hypercapnia, especially in the first week to 10 days in the extreme premature babies, should reduce. So anything above 55 to 60 centimeters should be an alarm bell, and ideally keep the PCO2 below 50 to 55 where possible. Obviously avoid hypocarbia as well, because it has a high risk of PVL. So as long as the pH is maintained above 7.22, you can accept 50 to 55 PCO2. Beyond the first 2 weeks, you can start accepting more hypercarbia. Hypercarbia has effect on the cerebral perfusion. The risk of IVH is more, and also increased risk of NEC has been shown with hypercarbia as well. BPD risk is more with hypercarbia, strangely. So we can't predict all the responses, so we have to be careful. Nitric oxide in the premature babies is used fairly frequently, but we should be limiting it to a therapeutic trial for those babies where there is documented pulmonary hypertension with severe RDS, especially where there is a setting of PPROM or low amniotic fluid volume. So if you have this setting, you can use the nitric oxide earlier before you go for very high pressure requirements and damage the lung due to that. So you can give a trial in these babies. Of course, as a desperate measure in the babies who are not coping, obviously it has not been really beneficial. Even if you use it, it doesn't make any difference. I'm talking of the 23 or 24 weekers where you're not able to oxygenate them just because of the immaturity. In these cases, nitric oxide doesn't help. Caffeine at a dose of 20 milligram loading and 5 to 10 milligram maintenance should be used to facilitate weaning from mechanical ventilation. Early caffeine can be considered for babies at high risk of needing mechanical ventilation, such as preterm babies on NIV. So this goes without saying that if the baby is on NIV, you'd give the caffeine immediately after birth. And even if the baby continues to be ventilated, we tend to keep them on the caffeine, especially after the result of the CAP study. But if a baby is intubated from the beginning, whether you start caffeine early or you wait when the baby is close to be extubated is still debatable. You can review my video on apnea of prematurity and the role of caffeine. There is no clear answer, so caffeine should not be taken as a drug totally safe as well. So use it with caution and don't exceed the recommended doses unless you have a clear reason to. An additional loading dose of 10 milligram per kilogram can be given, or an intermittent top-up dose can be given, but to go more than 10 milligram maintenance is probably not advisable. As the babies grow older, you may have to increase the dose of caffeine due to the pharmacodynamics changing. A short tapering course of low-dose dexamethasone, what we call the DART regime, can be considered to facilitate extubation in babies who remain on mechanical ventilation after 1 to 2 weeks. So whether you use it at 1 week or 2 weeks depends on the gestation of the baby. The smaller babies, you can wait longer. The relatively more mature, like 27, 28 weeks, if they're still ventilated by 1 week, because you would expect majority of them would be off ventilation by that time, you can use by 1 week. The babies below 26 or 26 and below, you can consider at 2 weeks. Opioid should be used selectively when intubated by clinical judgment and evaluation of pain indicators. Routine use of morphine or midazolam in ventilated preterm is not recommended. I fully support this as well, and sedation should not be taken lightly. We don't know about the long-term impact on the developing brain. Midazolam causes significant fluid shifting. You get a lot of edema related problems, fluid balance, renal function related problems. So use it for minimal periods only if it is essential. In terms of monitoring and supportive care, the core temperature should be maintained 36.5 to 37.5. I will request you to review my playlist on thermoregulation where many of these aspects are covered. IV fluid 70 to 80 ml per kilo in a humidified incubator with close regulation. Again, I have a lecture on fluid management in the small babies, including feeding. I'll refer you to that. Parenteral nutrition should be started from birth. There is no doubt that adequate nutrition from the beginning is very important. Amino acids, we start actually with 3 grams from day 1. Lipids start with 1 to 2 grams and increase quickly. We don't usually exceed 3 grams to 3.5 grams of lipids, but maximum 4 can be used if there is growth issues. Amino acid, we go up to 4 grams in most of the small babies. Enteral feeding with mother's milk should be started from the first day if the baby is hemodynamically stable, and that would mean if the baby doesn't need inotropes or is not hypotensive. So trophic feeds early on is best, and as soon as the baby is stable, you can start progressing at the appropriate rate. Again, the video I mentioned on feeding and fluid balance covers all these. In infants with the RDS, the antibiotics should be used judiciously and stopped early when sepsis is ruled out. If you are going through this and you have any concerns finding the videos that I'm talking about, you can just comment and I can share the link immediately. In terms of cardiovascular support, treatment of hypotension is recommended when there is evidence of poor tissue perfusion, such as oliguria, acidosis, and poor capillary refill. So the reason they are mentioning this is the concept of not going by the exact numbers. Of course, a functional echo, if you are able to do it by the bedside, it would guide you on how to approach it. And in terms of PDA treatment, again, you can refer my video on PDA treatment, a pragmatic approach as well. So paracetamol, they suggest when there is thrombocytopenia or concerns about renal function. And actually, I support the Iowa approach where paracetamol is the first line in the small babies. Invariably, there is a concern about renal function in all the tiny babies, and paracetamol has been shown to be reasonably safe. As I mentioned earlier in the comment on steroids, the long-term neurodevelopmental effect is probably a temporal and an association than an effect. So you don't need to be worried about it at this stage. So we will be waiting for further evidence, and unfortunately the Benedictus trial and the other studies did not give any clear verdict on ibuprofen. So the Iowa approach, there is evidence coming out as well from a first study as well that the exposure to the shunt is important. By reducing it, you may be helping these babies. So in the tiniest babies, treat the PDA early, start with paracetamol, and if paracetamol doesn't work after the first week to 10 days, you can go for ibuprofen. In the bigger babies, you can consider a higher dose of ibuprofen as well. The thresholds for red blood cell transfusion is set at 12 grams for those with severe cardiorespiratory disease, 11 grams for those who are oxygen dependent. For stable babies, they have put a cutoff of 7 grams at beyond 2 weeks. I don't agree with it. It depends on the gestation of the baby. In the tiniest babies where they are well off the mark of producing their own red cells, which you would expect by 6 to 8 weeks when the nadir is persisting, these babies are far off. So in the smallest babies, you would probably use a threshold of 8 to 9 grams if they're off oxygen in the first 3 to 4 weeks of age. And remember the evidence that the lower the hemoglobin goes, there is a possible risk to the brain as well as the increased risk of NEC. Transfusion associated NEC may be related to the lower level of anemia that we accept. So in babies at highest risk, so I don't know how this got passed as beyond 2 weeks, you put it at 7 grams. So again, the purview of this guideline doesn't need to include points like this which are controversial. So again, I would caution about this point. Surfactant can be used for RDS complicated by congenital pneumonia. Again, surfactant can be used to improve oxygenation following pulmonary hemorrhage, and surfactant can improve oxygenation with severe meconium aspiration. So there is no real change in these guidelines. So that's the last slide, and obviously, like in any guideline, a guideline has to support your management. There are reasons for modifying the guideline locally, and as I said, thresholds like this which you have to be cautious about. Maybe for a baby above 4 to 6 weeks or a bigger premature baby, you can apply this. So don't assume that just because it's in a guideline, everything is suitable for your use. You have to look at the evidence from your own perspective. The guideline obviously supports you, but you have to be cautious in how you use a guideline. And the point I made in the beginning about market sponsoring, again, is something to consider in a guideline which is widely used in the neonatal circle. So thank you for watching, and do share. Thank you.